Good afternoon, and welcome to My World Science, where we discuss everything scientific in our lives. Knowledge is power, and we hope to inspire you to use scientific knowledge to make your life and the world around you a better place. Having problems with your stomach? Today, we're going to learn how to make the most of your appointment with a gastroenterologist, how to prepare for your appointment, what to expect during your appointment, and the right questions to ask your physician to maximize your medical experience. I'm Noah Kittle, and welcome to My World Science. Today, we welcome to our show Dr. Jeffery Sherman, respected gastroenterologist at Cedars-Sinai Hospital, just a few blocks from Beverly Hills. A lifelong resident of Los Angeles, Dr. Sherman earned his undergraduate degree from UCLA, then went on to study medicine at USC. You may recognize Dr. Sherman from his appearances on medical shows, including The Doctors. In addition to patient consultations, Dr. Sherman has performed thousands of endoscopes and colonoscopies. A welcomed and respected member of the Beverly Hills community, we welcome Dr. Sherman to the show. Thank you for coming in. Thank you for coming today.
Nice to be here.
Yeah,
Appreciate it.
So, I'd like to start off with, what brought you into medicine? Why are you doing what you are doing now?
At a young age, I found myself as a math and science kind of brain. I would do math homework very easily. The English homework came with a little struggle. Yeah. My dad is a doctor, the same specialty as I am, so I was exposed to science and medicine at a young age, which kind of swayed me to that. But it was my math and science background that kind of steered me that way, and we don't want to write history papers or English essays. I mean, who knows what that's all about? But math, when there's a right answer, or science, when it's really interesting, that's kind of how it steered me toward medicine.
And I'm sure your dad, being the same doctor, made everything like really easy, probably for various tests.
Yeah, so, he would help me. He would know certain ways to help out. He didn't, guide me there or force me. He kind of, if I made my own calls, he would help me out along the way, and that would be another reason why I would be veering toward the science and medicine thing. But it was a very easy choice after a while because I understood the math and science a lot more than I did some of the other things in school.
That's good.
Yeah.
So you're a doctor of the digestive system,
right?
Gastroenterologist. Let's say somebody is feeling some pain or something weird with their abdomen, and they're recommended to a gastroenterologist. How should they prepare for the appointment?
The key is history, getting your story right. The patient should understand their medical history, not only gastrointestinal, but general medical history. Know your list of previous problems, list of prescription medications you're on. Then when it comes time to discuss your particular problem, just kind of pay attention to the details on when certain symptoms would act up, certain foods that may be interacting, certain foods would cause or certain foods would help. Eating anything would help. Not eating might help. Time of day. Just get your story as concrete as possible so that we can make the most of the time together, because certain diseases are certain parts of the history point to certain illnesses rather than others.
Yeah, I guess that makes sense because your body is built from your digestive system and what it absorbs. So I guess anything that you eat could affect any part of your body in a way.
Yeah, I mean, diet is very important. Certain diets are favored towards certain illnesses. IBS, patients are told to avoid certain foods to prevent spasm. Certain sugary foods and carbs, for example, can cause some spasm in some patients. Acid reflux, spicy foods, and tomatoes can cause a little acid reflux. So by avoiding these foods, you're helping your system. You're almost curing yourself. The problem is getting the patient to be compliant with these diets. It's a little bit tricky around here.
It can be very hard to avoid your favorite tomato pizza.
Right. With all the choices we have out there and the amounts we can have.
And speaking of diets, how many of the fad diets have you seen actually show positive results, or are some just meh?
They're pretty good if you can be compliant with them. Like I said, it's hard to do that for the long haul. You can do some low carb diets pretty easily. There's something called the FODMAP diet, which has a lot of sugar restrictions. Not only sugar, but certain vegetable restrictions. That can be a little bit tricky, but if you do it to a T, you can feel pretty good. Is it going to wipe things out completely? Probably not, but it can help you feel better. The Atkins diet, some of those keto diets, they're helpful. The weight loss, you'll feel better on it. But the biochemistry in your body is not going to sustain perfect results forever. And so there is a shelf life for these diets. You want to sort of incorporate your regular foods a little, eventually back into your diet.
How effective is having things like yogurt as for probiotics and keeping your microbiome in check?
Yeah, that's a good question. The probiotics are generally in moderation. I say in moderation because if you overdo probiotics, they can cause IBS and trouble symptoms too. So you want to get the right amount of the right bacteria in the right place, and by overshooting that, and if you take the wrong dose or the wrong amount of colonies, it's going to enter the small bowel, go to the wrong place, and cause some side effects and things. So it's a trial and error, and like I said, not everybody does well on probiotics per se. So you get some advice from your doctor and know which one to take in which quantities, and when you're overdoing them, and look at some of the warning signs to back off of them. So there's a give and take to the probiotics.
One of the things in the media and just everyday life that we hear a lot about are colonoscopies.
Yeah.
Because apparently the prep period is horrendous.
Well, it's recommended for a long time. Now it's moved up to age 45. It was recommended at age 50, so now it's age 45. You get your screening colonoscopy. The procedure itself is very easy to do. You come to the endoscopy center and you're out of there in a couple hours. The day before, to see the colon very well, you got to clean out your system.
Right.
You've heard of some cleanse diets. I mean, this is like cleanse diet on like mega steroids. You drink only water or juice for a day, and then you take a really powerful laxative that keeps you in the bathroom for like 4 or 5 hours, and your system is cleaned out. So yes, it's a little inconvenient because you're at home and you're not eating much, but the information that you gain from the procedure the following day is really worth the inconvenience of the prior day.
Right. And could the process of prepping for the colonoscopy affect the results at all? Because I imagine a colon that just worked a bunch probably looks a little different besides the feces in the way.
Yeah, well, I mean, some patients need extra preparation time. We don't really know that. We know their history of being on the constipated side or having a sluggish bowel. Their colon may be a little bit more tortuous and twisty. Patients need a little extra time there. The thing is, you want to get as clean as possible because inflammation, small polyps, and just the procedure itself can be a little bit more difficult and not seen if there's debris in the way and it's just not a clean colon. So the preparation is the key to the colonoscopy. We'll cancel the case. We'll cancel the procedure if we go in there and say, hey, it's not clean enough. We got to come back another day. If a patient says, I tried this stuff last night and I just don't think I got clean enough, we'll say, well, we'll take a look. But if you're not clean enough, we got to bring you back because it's just not worth it. We got to see everything really cleanly.
Right. And on polyps. So polyps is really kind of what you look for in a colonoscopy. And ever since I've learned about polyps, for some reason I've always thought of them as being like moles in your colon. But I have a pretty good feeling that's actually not what they look like. In fact, I believe
you have some photos, but polyps are at the.
There's no polyps there, right?
This is a clean surface of the colon here. Yeah, okay. Polyps at the genetic level. There's a mutation in the colon cell, and it's a different kind of cell, and then that cell will divide and divide and divide, and it grows into a little bump. And it's a growth or a little bump.
Oh, that's
this is a big polyp here. You see the difference between the normal colon and the polypoid mucosa there. Not many abnormal cells. So that's what we look for when we do colonoscopy. We want to make sure we get rid of these because these can turn into colon cancer. They start out small, oftentimes stay small and stay benign, but there are a few that turn into cancer, so you want to grab them all because you don't know which ones will turn into cancer or not.
Can you grab them the same day that you're looking?
Yeah, so we have tools that go in there and grab them. There's one way to do it. If it's a small enough polyp, there's a forceps that just kind of pinches the polyp, and you just kind of yank it off. It kind of sounds barbaric. Okay. Or if they're big, like the one you see here on the screen, you get like a lasso, like a noose, and you burn it off with a little energy, and that will cut that one off. Yeah.
Wow, you have to burn it off. Okay.
Burn it off. The bigger ones need to be burned off. There's a big blood supply into these polyps, remember. That's how they grow. So that burning effect will clot the blood so you don't have a lot of bleeding in the colon.
That reminds me of Star Wars, actually, because the lightsabers are always so hot and they burn all the body parts. And
exactly.
With blood.
Same idea.
It's the same principle.
Right.
And seeing how the polyps is so big, I guess, in comparison to the like interior of the colon. Could somebody feel polyps existing?
You see, the short answer is yes, although it's unfrequent. You see the effect of the polyp more. You see a little mucus, you see a little blood in the stool.
Oh,
That
okay.
tells you there may be something big going on up there. A polyp, like a big polyp like this, there's still a lot of colon space, so everything can just bypass that
Okay,
particular
all right.
polyp. It's when you get to a larger tumor that takes up 80-90% of the colon center that you'll feel. That will be
Oh, boy.
uncomfortable, painful. Your bowel habits will change one way or the other, and you still also might see the blood and mucus as well, but that could be a painful situation.
Would people who tend to who are more constipated and have harder stools as a result, again, could they maybe feel that a little bit more just because their stools are solid rather than smooth?
They would feel that, yeah, just by virtue of the fact that their bowel habits are a little bit irregular, they would feel a little bit more spasm and pressure down there, and that would translate. And it wouldn't necessarily mean they've got something terrible.
Right.
And that's what I want to emphasize is most of the time it's not that. It's more of a spasm type of situation. But that's a setup for polyps and colon cancer. If you have increased constipation, the stool's rubbing up against the mucosa a lot, you want to have somewhat regular bowel habits, a high fiber diet, good in fruits and vegetables, not a lot of fat to make the stool very hard and uncomfortable, and that will prevent the presence of cancer and polyps.
Okay.
Yeah.
Let's see what else we have here. Ooh, those are polyps again?
Those are polyps in a slightly inflamed colon in that area, and that particular one in the background here, that one would be removed. This one here may be removed too. They're all looking a little bit, they don't belong.
No, they don't.
You know.
Let's see what else. Oh, that does not look healthy.
Yeah, that's an ulceration. That looks like a rectal ulcer. That can also happen in constipated patient where the patient don't go to the restroom over days. It happens. Patients don't go to the restroom over several days to a week or even longer, and the stool sort of wears into the lining of the colon wall and causes what we call a stercoral ulcer there, and that could bleed and certainly be uncomfortable and be a problem.
I actually had that situation when I was like maybe 8 years old.
Yeah.
I had to be admitted to the hospital because I had feces going all the way up through my small intestine. But because I was so young, I mean, they might have checked for this. I have no idea.
Yeah.
But because I was so young, anything like this probably wouldn't have hurt me.
Right. I mean, you want to jump on it early. You want to go to the ER like you did and see. This can be seen on a CT scan because the colon wall is thick and swollen.
Okay.
They wouldn't be able to see that until everything passes through. But they can see the CT scan or the X-ray that your system has a lot of stool in there, and then the key is to just get it out. It's difficult to get it out in some cases.
Right. Let's see. Okay, so now this is Crohn's disease, and just from my first look, it just looks like a whole bunch of polyps.
Right. So these are what we call pseudopolyps. In a Crohn's disease patient, their colon gets inflamed. You try to heal it. They're okay for a while. Then they go through a flare-up and it gets inflamed again. So over time, it goes through this flare, healing cycle. And as a result, you get a scar tissue or pseudopolyps. Now, there's no way you're going to remove all these polyps. They're called pseudopolyps because in the Crohn's patient, they're not the same kind of polyps that will turn into cancer.
Yeah.
They're just a scar tissue type polyp. You want to remove one, make sure it's a pseudopolyp, and just know that the patient's got a lot of these pseudopolyps. You'll keep an eye on them with yearly colonoscopies to make sure that they're the rest of the healthy part of the colon doesn't turn into cancer. But these are what we call pseudopolyps that you see in Crohn's and ulcerative colitis.
Wow. Let's see. I believe this is just.
This is what we call melanosis. This is a changing of the color of the colon surface. You see, it looks like
not just the image.
A leopard skin look. That's a high amount of what we call melanin or a pigment.
Oh.
That's because this patient was on, laxatives and, supplements. Needed to go to the bathroom. They're on the constipated side, so they need to rely on these vegetable laxatives and things that they buy to help them go. And over time, it turns the colon into this color. This is a benign condition. You can have this, and it's not a setup for any trouble. It's just a change in color. It works just the same. and you have no increased risk of colon cancer with this. It's just a funny color. We see this a lot.
Okay.
Yeah.
But yes, on laxatives, if you do laxatives too much, your colon, I believe, will forget how to work.
A little bit. It takes a little bit of time, but yeah, the colon will then become a little bit relaxed. The laxative does most of the work over time. The colon becomes a little bit less tonic. It doesn't move as well. And then you sort of, the second you stop taking the laxative or forget, or there's a time where you can't get to them, your colon just starts to build up. It won't do its own thing. So you don't want to take these too frequently, too often, every day, or you had 6, now you need 8, now you need 10 pills. You want to try to keep it low and use more of your diet, water intake, physical activity, exercise to help you go, and not just rely on a drugstore medicine. And before you know it, you'll need to. You're spending half your budget on pharmacy stuff.
Aren't there different types of laxatives? Because I know that there's laxatives that really make your colon, force your colon to work. But then there's other laxatives, such as Miralax, which I believe just soften the stool.
Yeah,
instead.
there's 3. You can soften the stool with Miralax or stool softeners. They help. Obviously, the stool will be eliminated more easily. You can allow more water into the channels. Yeah. There's osmotic laxatives that allow more water into the colon lumen and prevent reabsorption. So it's almost a wet, watery stool after it's all said and done. Okay. And then there are the laxatives that work on the colon muscles, the magnesium types that speed it up and get things going there more quickly to, get things out of there before too much water can be absorbed.
Would the softening laxatives be damaging long-term like the magnesium ones would?
No, not necessarily. They're working more on the stool itself.
Yeah.
It's like a lubricant. So,
it's
the softeners are pretty safe. Everything's pretty safe in moderation. You don't want to just overdo it, and you don't get you're helping yourself in the here and now, but in the long haul, it can be a little bit challenging.
Right. Let's see. That's right, because you not only do you specialize in the colon, you also do forgot the word.
The endoscopies, which is a look into the stomach too. Same idea, same technology, just looking in through the mouth and into the stomach. You get anesthesia. You get anesthesia for the colonoscopy, of course, because it's uncomfortable. And then if someone's putting a camera down your throat, you need some anesthesia for that too.
I imagine.
And we see the entire esophagus, the entire stomach, and the first part of the small intestine just as it exits the stomach.
And this is what people would get if a doctor suspects they might have an ulcer, stomach ulcer?
Right. So you have abdominal pain high up. Maybe you have some acid reflux. You want to look in the stomach. Maybe you think the patient has an ulcer. You look in there. You look for bacteria with the biopsy. You look for the ulcer. You look for other inflammatory changes of the lining of the stomach and esophagus to see if there's an ulcer or just inflammation.
Wow.
Yeah.
Do some more here. Oh, I believe this is the stomach?
This is the stomach. This is basically a normal appearing stomach. The bottom end of the stomach, what we call the antrum, the exit of the stomach down there. You eat all this food and it all has to fit through that little hole. It's about the size of a quarter. So the stomach grinds up the food pretty well before it exits into the small intestine.
So you're looking at the stomach right now, and I'm noticing there's nothing in it. There's no acid at all. So
right, the acid you can't really see. It's just kind of along the surface of the stomach and then of course when we do these procedures, we ask the patient not to eat for 12 hours, so its stomach is completely empty. If their stomach is working right, it should be pretty empty. It should be completely empty by the time we drop a camera down there.
But if there is food in it, then it would look like a soup, I guess. Stew.
Yeah, it may look like what they ate prior, or it would look like ground up whatever. I mean, it just can look like a lot of mush. It doesn't really, you don't really know.
So
because it grinds it up, so the stomach is grinding, but and in those patients they have a stomach motility disorder, so it's not moving it through, but it's grinding it there. So it looks a little bit. It's hard to recognize the food, but you still won't be able to do much because it would be covering the surface of the stomach, and you won't be able to see anything.
I guess it's pretty nice for me to know because I used to always think that the stomach has like acid in it 24/7, but I guess no, it's not the case.
Not the case, but it does have some peaks and valleys. It's in there most of the time. You make a lot of stomach acid at night, believe it or not.
Interesting.
And you want to protect your stomach at night if you're having some stomach trouble or acid reflux. But food helps buffer the stomach acid. Stomach acid, by the way, is not used to digest food. It's used. We talked about the biome a little bit earlier. It's
Yeah.
used to regulate that. So you
Really?
you still want to keep your stomach acid if you can.
So the acid doesn't actually digest the food?
Correct. The acid might break up some of the food up here, but it's doing that just kind of because it's there. It's not because it's supposed to. The stomach acid then goes downstream and then kills off and regulates the bacteria in your system, so that remains as optimal as possible.
Unfortunately, I think we're a little out of time here. Thank you very much for coming in to talk to us today, Dr. Sherman. I really enjoyed our conversation, and we appreciate your time.
Thank you.
Thank you. Thank you for joining us today at My World Science. To recap today's show, remember, before your appointment, bring previous medical records, a list of current medications, and an outline of your current symptoms and complaints. As with all medical shows, please discuss any questions with your personal physician. Please join us next week for more scientific exploration, and don't forget to follow us on Twitter and Instagram at MyWorldScience or email us at MyWorldSciencetv@gmail.com. Until then, think inquisitively. Thank you for coming today.